Thank you. My name is Paul Malik. I'm the Associate Director on the ION 440 program. And it's a privilege to be here. I'm representing actually a larger research team, a very highly trained and cross-functional team. And also I'm representing not only those at IONIS, but your physicians and your experts who we have been collaborating with to deliver some of these results. So Christine talked to you about what we're doing in the ION 440 development program. I would like to tell you today about the part of the development program that doesn't explicitly involve ION 440. And a lot of it involves you and what we're learning from you. So we're going to talk about what we're learning together, uncovering the natural history of MECP2 duplication syndrome. These are my disclosures. Similar to Christine, information contained within this presentation is not medical advice, and decisions about care should be directed to and discussed with your healthcare provider. Okay, this slide I showed in Houston, and I think it bears repeating. What is natural history? It's a term you've heard mentioned almost countless times already, and we're only on the third talk of the day. Natural history refers to how a disease develops and changes over time without an intervention. It helps us do things like learn more about how to diagnose, manage, and treat a condition, to identify the unmet medical needs faced by the children as well as the caregivers of those children. It helps us determine the best tools to measure meaningful changes over time, and then ultimately design more efficient clinical trials for potential treatments. The path to bringing a potential treatment is long, and natural history studies provide a very important foundation. And so this is the recommendation from the FDA for developing treatments for rare diseases, is that immediately after we have a plan, the first step is a broad and effective natural history study. We have to understand what is the disease we're developing a treatment for. Every disease is different, and this is not just another epileptic syndrome or another development syndrome. It is MDS. And so a lot of the research we're going to show you today is moving towards understanding what is MDS and what does it look like to treat it. So some of the important questions natural history helps us answer, which I hope to shed just a little bit of light on today. When a child receives a MECP2 duplication syndrome diagnosis, how can the primary doctor prepare the family for what they might expect? Every time I come to one of these conferences, I hear from you, when my child was diagnosed with MDS, the doctor had a confused look on their face, or they didn't know what it was, or I saw them pull up Wikipedia. This research and what we are aiming to do is to broaden the knowledge so that most neurologists have heard of this and that there is an answer when a child is first diagnosed. Throughout the journey of MDS, there are specific milestones, and there's questions about those milestones that for the most part are unanswered. One of those questions is, if seizures start, what are the next steps? And in a child with seizures, what works best? And Dr. Pelevin was talking a little bit about the early research that's going towards answering those questions. And as we look toward potential treatments, how can we track if a potential treatment is working? So I will summarize key findings from 3 ongoing natural history studies that are sponsored by IONIS, but of course reflect collaborations broadly, not only in the United States, but also, well, actually, these are all in the United States. So first, it's the Vanderbilt Neurodevelopment Study. So this is a primary collaboration with Sarika Peters. You saw her mentioned already today. This is where we administered the standard clinical scales in development to 62 predominantly males with MDS to evaluate what do we get when we try to quantify the disease and what's the best way to quantify it. Then we have the Citizen Study, which is a medical record-based study where we can look from birth over the entire lifespan of MDS to see what's the full picture of this disease and how does that evolve over time. There's currently 50 individuals analyzed in the Citizen Study, and we're pending analysis of 60. So thank you to everyone if you signed up for that from the US. And then Christine was mentioning that the NH6 study has completed. and its primary goal was to evaluate the clinical and caregiver outcomes and how those change over time, as well as identify potential biomarkers. And in a way that mirrors the ATTUNE clinical trial, there were 29 individuals ultimately enrolled in that study, and thank you to those individuals, as well as our study investigators. David Pelevin is one, and Eric Marsh is another one you heard from here later today. So it's not just the data that tells us what MECP2 duplication syndrome is. It's all of you. And I always learn something new when I come to these conferences, and I really appreciate that. And so I wanted to reiterate that we are listening. No one knows this experience better than those who live it every day. And it's not the clinical trial alone that tells us what we need to know. You do. And so with that, we'll start with the Vanderbilt Neurodevelopment Study. This is a manuscript in preparation. Here's where we start learning about how we can quantify MDS. What is the condition, and how does it relate to other conditions as well as typically developing kids? One way to evaluate a child is in a performance measure. So the child will sit down in an examination room with a clinical rater, sometimes a physician, sometimes a psychologist, and evaluate different domains like motor, language, cognition, other aspects of their function. And that might depend how the child is doing that day. They might have just experienced a seizure. They might have just come out of hospital. They might not like the rater. They might be uncomfortable with them, right? And so there's actually quite variable results of what we see. And so we were also interested to evaluate caregiver-reported measures of the same thing. So many of the families who participated in this study, they sat down and they talked with one of these raters for approximately 45 minutes in a semi-structured interview. That's called the Vineland Adaptive Behavior Scales. So I really appreciate caregivers being open, transparent, consistent, and honest when they have these interviews, especially when we do them multiple times, sometimes in quick succession. And so I thank you for your commitment to the integrity of the research, because this is some of the most important and accurate information with the way we learn about MDS. Because you're able to tell us about that child's usual performance better than anyone, especially when we're dealing with those other variable factors, something that might have just happened or something acute, right, which might be confounding and adding noise to what we're trying to picture. And so what we saw in the neurodevelopment study is that those caregiver-reported measures, when we looked at motor function, language, cognition, they were highly correlated with the direct in-clinic testing. And so I would like you to know that your observations are valid to use in clinical trials. That's the first thing that we're learning together. This is a specific piece that we learned from the data when we looked at communication. And it's something that we've heard from you all along, is that absence of speech isn't absence of understanding. And we can see that in the data. And so when we looked at the 62 boys with MDS, receptive communication, which means the ability to understand words, was a relative strength across the lifespan, even when spoken language was among the most limited domains. And so when we measure this, the receptive skills were consistently 3 to 5 months ahead of other adaptive abilities. So when we chart developmental function, we chart it based on a typically developing child and what they would normally, milestones that they would normally achieve at different months of age. And so the difference there, 3 to 5 months, is quite substantial. Ultimately, this means that many children with MDS may understand more than they can express, and validating what you have long observed. And so I want this data to serve as an encouragement that even if they can't say it, they might get it. So keep talking, showing, and connecting. This study also helped us learn about impacts of epilepsy. Every child with MDS has their own rhythm, but seizures can change that tempo. And so when we compared individuals with epilepsy versus those without, adjusting for age, the children with epilepsy had functional skill levels that were 5 to 13 months lower compared to their peers. In the graph here, you can see that almost every domain is affected, from receptive communication, expressive communication, down to motor. And it's the motor domains that are the most affected. And so therefore, the therapeutic goals may shift following the onset of epilepsy. And it's background information like this that's important for your physicians, your your physiotherapist, your occupational therapists, to understand as you approach the best treatment paradigms for your children. Okay, we're going to switch gears to the medical record-based study, Citizen Health Platform. So the way this study works is that individuals in the US provide consent on a platform for an organization called Citizen to retrieve all their medical records, prescriptions, images, MRI, EEG, and all of those interpretations, put it into a standardized data set where everyone's terms are the same, events are coded similarly, and then we can analyze that in a very systematic fashion. And so one of the things we focus on with this is epilepsy. And so we think it provides powerful insight into the profile of epilepsy. A commonly quoted figure in literature is that about half of boys with MDS have seizures. And when you look at a snapshot in time of individuals across many ages, that is true. But when you model this by time to event, it became clear in the data that seizures are nearly universal in MDS by the time those individuals reach adolescence. The seizure presentation also emerged in a consistent pattern. So there were atonic seizures, the sudden drop type, that appeared as a hallmark feature, often emerging around age of 7 years, and those appeared to be followed by loss of motor skills. The seizure types could start non-specifically or generally, and then shift over time, evolving into that atonic or Lennox-Gastaut presentation. We know that the seizures became severe from the medical records. Most individuals with MDS that developed epilepsy, we saw them be hospitalized at least once related to seizures, and those hospitalizations could be up to 1 week in duration. And so for now, unfortunately, epilepsy and MDS has few answers. Dr. Pelvin started talking about the medicines that are being tried. And here in the US, in the data here we're showing from the US, you can see the number of prescriptions that individuals have been trialed after they've begun seizures. So while levetiracetam and benzodiazepines are the most prescribed first line, those are quickly added on to or discontinued as the seizure profile continues to evolve. And so on this graph, on the x-axis, we have the time since the onset of seizures in years. And then this graph is the number of different prescription anti-seizure medicines that the child has tried. And so you can see some children, even within 2 years after onset, they've tried up to 11 anti-seizure medicines in similar trajectories for most children. And this gives us an indication about really it is a treatment of refractory epilepsy. Okay, the Citizen data goes a long way to also showing us that MDS is not just another epileptic syndrome or an epileptic encephalopathy or developmental syndrome. We want to encourage future investigators, as well as all of your supportive teams, to treat the whole syndrome and not just the seizures. And so we can look through the medical records and see which body systems are most affected, when they are affected, which groups, there might be constellations of symptoms that appear together and constellations that appear in others. And we can start to understand more about what this condition is and how to treat it. One way to understand differences between individuals with MDS is to understand the relationships between the genetics and the lived experience of that child. And so with medical records, we're validating what Dr. Pelvin published earlier this year, is that generally those with the terminal duplications or the longer duplicated regions, larger duplicated regions, have more severe disease. And so we see congenital hypotonia or floppy baby syndrome or lower muscle tone as much higher in those with terminal duplications, epilepsy generally higher, microcephaly, tube fitting, airway malacia, and recurrent urinary tract infections. Now, interestingly, an autism spectrum diagnosis is higher in those with shorter duplications, and so is a medical code of abnormal gait. And this made sense to us because a child has to have a baseline functional ability to receive an autism diagnosis, as well as the abnormal gait code is only applied when individuals have an independent gait. And so this is the way that we learn through medical codes about your experiences in your healthcare teams and the diagnosis that you're seeking and the types of care that you're receiving. And we look to learn about this and also understand how it can be improved. Okay, we'd like to offer a big thank you to all the participants of the NH6 study. Ultimately, there were 29 participants at 5 study sites. Those individuals completed 167 clinic visits. There were 45 lumbar punctures performed, and there were 120 blood draws. And so that is quite a commitment, and the volume of data as well as the quality of data has been exceptional. The study ran from October of 23 until just last month for a period of 2 years. We are beginning to show the initial data on electrophysiology at the American Epilepsy Society in December of this year. But there's so much work left to be done. We're beginning to analyze the cerebrospinal fluid that's been collected. We're preparing the clinical study report of all of the clinical outcomes. And ultimately, this will be the primary data set that's used to streamline and interpret the ATTUNE clinical trial. NH6 showed us more than just the data. It showed us that the community is ready for clinical trials and that they're able to participate in some of these complex and powerful assessments, such as intrathecal administrations and complex clinical exams. Okay, so here's a brief summary of some of the biomarkers that we looked at and what we've learned already. So we're learning how to measure through these biomarkers the biology of MDS. The first thing we measured was brain signals through electroencephalogram. We found that the resting brain waves were stable over time, barring major milestones. And so this tells us that any changes in response to an intervention might be meaningful and important. Further, when we looked at MDS and we looked at brain activity, that told us about the developmental activity of that child. Next, we looked at pupil responses to a light flash. This tells us about the autonomic nervous system. In general terms, the autonomic nervous system is responsible for how our body breathes, how the heart beats, and how our eyes respond to things like light. And when we look at kids with MDS, in a typical adult, when we get a light flash in our eye, our pupil will constrict, and then it'll open up again. And so when we look at the boys with MDS, that constriction, the time it takes to begin constricting, as well as the power of that constriction, is about half as much. We investigated this further in the NH6 study, and so even within boys with MDS, in a very small sample, we found that the ones with faster and more dynamic responses to this light flash actually had higher cognition. And so when we understand which direction these biomarkers would move and what that might represent, they become more powerful as we begin to establish more clinical relevance. We also looked at biochemistry, so what we can measure in the blood. We shared this a little bit at Houston last year. The relationships are becoming stronger, and so the bilirubin pathway appears to be backed up in boys with MDS, meaning the enzyme that forms bilirubin might have lower expression or activity, or it's impacted by MECP2 in some way. And so generally we see that the serum bilirubin is lower in boys with MDS, and then when we break that apart within the disease itself, those with the lowest bilirubin were the ones with the greatest disease burden. So this is telling us about the clinical severity of the condition. So ultimately, once we've established the relevance of these potential biomarkers, then we can interpret when these change in response to an intervention, what does it mean? In the NH6 study, we're also evaluating many of the new instruments that Dr. Pelevin was talking to you about earlier today. Those include the MECP2 clinical global impression of severity, as well as the ORCA. The clinical global impression of severity was a wonderful effort by the community as well as the experts in this condition to bring together what are the most important aspects of the child's life and their clinical presentation, to put numbers on in order to characterize what that child's quality of life and it really is. And so it measures both overall severity of the condition as well as the change over time in those 6 major domains, which are communication, gross motor, fine motor, seizures, social interaction, responsivity, and attention. So thanks to the MECP2 Duplication Foundation for all that they've done to contribute to that effort, especially in the generation of that scale. The observer-reported communication ability, no one knows best how your child communicates except you, especially those unique ways in which you have a relationship and you see the way that they respond or see what they understand, or they might have symbols or even assistive devices. The ORCA intends to measure exactly that. And so while in the Vineland, we might be asking you questions where you might have to say, no, my child really can't do that, and it could become discouraging. The ORCA is a tool that's developed for MDS, and it's a communication measure that lets the parents say, yes, my child can do that. It's more granular, and it tends, we want to accentuate the strengths and look as the child gains future strengths. It covers expressive communication, receptive communication, as well as pragmatic communication. So that's what we're learning together, and that's what we've learned so far, but there are many next steps. So specifically for our clinical research team, we look to solidify the information that I've shared with you, as well as begin disseminating that more widely. Disseminating the understanding of MDS as a unique syndrome that will ultimately define the unmet need faced by the patients and caregivers. We're going to continue to build the evidence for suitable and even novel clinical endpoints, changes in which would reflect the substantial evidence of effectiveness for an investigational medicine in MDS. And finally, we're going to continue to refine potential biomarkers that capture the biology of MDS. Many acknowledgments from many individuals at IONUS, at Citizen Health, at the Vanderbilt Institution, and of course our NH6 study centers. Thank you to the patient advocacy groups, MECP2 Duplication Foundation and Cure MDS for their efforts across many of these initiatives. And thank you especially to the people with MDS and their caregivers who participated in each of these studies. And we look forward to sharing much, much more as we solidify this scientific information for physicians around the world.